Hello, everyone. Welcome to our presentation today. I'm Matthew Stanford, the CEO of the Hope and Healing Center and Institute, and I'll welcome you to our presentation, which is part of the A.J. Weisberger Education Series on Addiction. I'd like to thank Camille and Mark Weisberger for their generous gift that makes this series possible. Well, today we have a very exciting presentation by Dr. Alicia Kowalczyk, and let me introduce her so we can get going here. She's going to be talking about what to know about fentanyl. Dr. Alicia Kowalczyk is an associate professor with Baylor College of Medicine's Department of Family and Community Medicine, a board-certified physician in family and addiction medicine. She's medical director of Insight, the screening, brief intervention, and referral to treatment program for the Harris Health System. She also serves as medical director of Santa Maria Hostel, which provides state-funded residential drug treatment to women and their children in the greater Houston community, and the Houston Recovery Center, which operates a sobering center in partnership with the City of Houston and the Houston Police Department. Dr. Kowalczyk is a graduate from the New York College of Osteopathic Medicine. She relocated to Houston in 2004 and joined the Baylor College of Medicine faculty, working as a family physician in a community health center before moving to the Insight program. And her passion is caring for families affected by addiction. So I am going to turn it over to Dr. Kowalczyk for her interesting presentation today on what to know about fentanyl.
Okay, and let me just pull up my presentation. Can everybody hear me okay? All right, thank you. So let's see if this share thing works. And I'll start slideshow from beginning. Yeah, there we go. And let me see also if I can, I am not able to pull up the chat. So if folks just want to unmute and ask questions, we will have time for questions at the end. Or if someone with HHCI plans to monitor.
Yeah, I will monitor the chat. And if you have a question, just put it in the chat and I'll pull it up at the end.
Me bringing this presentation to you is part of a grant-funded, SAMHSA grant-funded program through the Houston Health Department called Frontline. I put a link or a QR code to the project's webpage on the City of Houston's website. Our partners include Baylor, Houston Fire Department, the Houston Recovery Center, UT San Antonio, and now University of Houston. So it's a big collaborative effort, which I love. And initially, our focus was on supplying all HFD units with naloxone, and that's been accomplished, and we continue to ensure that they're well stocked with naloxone. And to provide training to all first responders within the Houston Fire Department. And that's also happens and continues to happen as new folks come on. We also do layperson first responder trainings. So folks that aren't medical experts, but that may encounter someone with an overdose in their life or their work. And then we have a real-time peer support response through the Houston Recovery Center for overdose victims that are transported to any area hospital by HFD. Our peer support team will meet the person in the hospital at bedside. If the person's not able to interact with that peer support person and their family is with them, they interact with them, train them on overdose education and provide them with some naloxone because the highest risk for overdose, person at highest risk to overdose is someone that's overdosed before. And so we really want to, equip people, with that life-saving medication. And then really trying to engage in dialogue with the person who's overdosed, if they're able to, or the family about the resources available and trying to link people into long-term treatment for their opiate or other substance issues. And then we also do some coordination with other prevention programs in the community. So we have planned redundancy when that's helpful, and really find where gaps are and try to fill them with our various programs. So just a little bit about that to get started. So I'm going to start with a little bit of the statistics on the opioid epidemic, which a lot of folks attending are probably quite familiar with. maybe share a little bit, different way of presenting this information. Again, we've had nearly 645,000 people die from an opioid, not all overdose, but opioid related overdose over the last essentially 2 decades. And we see that we're now entering what we call the 4th wave of the overdose epidemic. So in the 90s, we saw a lot of overprescribing or very generous prescribing of prescription opioids, and that kind of kicked things off. But as overprescribing, which still happens, but has gotten a little bit better from the medical community, has really responded since the early 2010s. We saw that the majority of overdose deaths involving opiates started to involve street opiates or illicit opiates like heroin. And then toward the middle of the 2010s, we really see the entry of illicitly manufactured fentanyl enter the drug market, and really saw a huge increase in the rate of overdose increasing. So really saw overdose rates take off again. And now we're talking about a 4th wave. And what we're seeing now is that fentanyl has infiltrated not just the opiates on the illicit drug market, but is now being incorporated or contaminating other drugs from the illicit drug market. So we're seeing it in methamphetamine. We're seeing it in pills that are pressed and being marketed as benzodiazepine like Xanax. We're seeing it in cocaine. We're seeing it, of course, in heroin. And we're starting to see it being marketed, fentanyl, illicitly manufactured fentanyl, being marketed directly for what it is. But also, folks not realizing that the methamphetamine they just bought also contains the powerful opiate fentanyl, and having very little tolerance to opioids, as that's not their regular drug of choice, that really increases the risk greatly for those folks of overdose. So we're really now talking about the 4th wave. So it just keeps coming, unfortunately. A little bit about opioid classification. So opioids have been around a long time. We have the natural opioids, which are derived from the poppy plant. And you can see this is a picture of a poppy plant, an opioid poppy. Although all different kinds of poppies, different varieties of poppies, you can isolate some opioids from the resin, which you can see here. It's scored, and then this resin kind of comes out and is collected. And that's where we get the natural opioids like morphine and codeine. You distill this stuff down, break it down, and you get these 2 natural opioids without additional manipulation. So it's gathered and then processed in the lab, but they're really not changing the chemical structure. They're just isolating these compounds that are already in this resin that comes out when you score these pods from the poppy. And these are some of the tools that are used to score them. So there are legal poppy fields where, pharmaceutical drug manufacturers buy this resin that's been harvested. And there are lots of, unfortunately, illegal poppy fields around the world, now concentrated a lot in Afghanistan and the Far East, as well as in Mexico and Central America drug markets. Then we have the semi-synthetics. So these take this resin and extract kind of raw natural opioids, but they're also additionally processed to create new chemical compounds. They're not simply just distilled and purified, they're actually new compounds produced. So these are the semi-synthetic. So you have to have this poppy stuff, but you also need to do some more manipulation in a lab. And you can see this is a quote unquote lab, you know, illicitly manufactured synthetic opioid like heroin. And actually, this is a heroin production a photo from, I believe, from Afghanistan. And then we have, can be synthesized in a pharmaceutical grade lab, like we see here. And then we have the completely synthetic. So completely synthetic means you don't have to have a big field of poppies growing that you have to, if you're doing this illegally to produce illegal substances, have to somehow hide, right? You just can do it and mix this stuff up in your lab. And we have kind of the pharmaceutical grade lab again, and then we have these clandestine labs. And this is fentanyl. Other synthetics that folks might be familiar with, tramadol, which a lot of folks don't realize is an opiate, and methadone. But we see, again, a real switch or movement in the illicit drug manufacturing world from producing natural or semi-synthetic opioid products to distribute on the market. Which again requires you to kind of have and manage these fields of and keep them undetectable by authorities that might want to shut them down, versus you just get a couple of these little wash basins and mix up some stuff. So a lot easier to get this in production and to hide the production and get things moving along. And so we've seen that switch. So again, what is fentanyl? We have prescription fentanyl. So this is pharmaceutical grade fentanyl that's produced legally. There are, you know, legitimate reasons for someone to be on fentanyl, particularly around cancer pain and post-op pain. And then we have IMF, or illicitly manufactured fentanyl, which is, again, what we're seeing really infiltrate the drug market. It's rare that we're seeing on illicit drug markets the prescription fentanyl. It's hard to get, it's heavily regulated, and you can see, you know, it comes in these vials and things like that, which again, harder to divide up and distribute than, you know, when it's synthesized illicitly and made into these powdered products that can be pressed into pills, etc. Fentanyl is 50 times as potent as heroin. It's 100 times as potent as morphine. So it's going to have action in the body 100 times as great milligram per milligram as morphine. This is its chemical structure for anybody that was really enjoys chemistry. That's what it looks like, its molecular structure. And this is just to show you how potent it is. So a lethal dose of fentanyl is equivalent to 2 milligrams, is considered a 2 milligram dose or higher. 2 milligrams is about the size of 2 regular grains of just your average table salt. So really small quantities are lethal. So a little bit more about fentanyls and overdose, and there are, you know, different compounds that are all going backwards a little bit, kind of look like this structure. They might have an extra N or an extra O or something out here, but they all work in the body very similarly. So there's a whole class of fentanyls. But we'll just lump them all together because they all do the same thing, which is kill people. We know that over 150 people die every day from overdoses related to synthetic opioids, primarily the fentanyl class of opioids, in our country. That means while we're together today on this Zoom, we will have lost 6 people to overdose related to synthetic opioids. 7 out of 10 pills that the DEA has tested out of seizures that they've made have contained at least 2 milligrams or more of fentanyl. in their drug seizures. So this is not uncommon. You may have seen, there are headlines about overdose pretty regularly in our country. One that come to mind fairly recently, although when I looked up this headline, I was surprised. Well, it was over a year ago now. So in March of 2022, there was a big news story about West Point cadets who were on spring break in Florida. They were bought what they thought was some cocaine to try and to use while on spring break, and it ended up having fentanyl, and a number of the cadets overdosed. So again, we're seeing it in other products, not just things labeled as opiate. And so the DEA has started the One Pill Can Kill public messaging. It does not take, it's like roulette now when you're buying illicit products from the illicit drug markets. You never know if it's going to contain fentanyl, and if it does, how much it contains. Again, these are totally unregulated products, and you don't know what you're getting, but we do know 7 out of 10, those aren't that great odds to avoid getting a deadly dose of fentanyl. And so again, we're seeing, where we used to see folks overdosing that may have had a long history of use of opiates, and it just kind of ramped up over the years and to where it was lethal. We're now seeing that, young people that are just, hey, try this, and they've never tried anything before, but someone hands them something at a party, it contains fentanyl, and they're dying. So we really need to get that message out. And again, if you remember from the previous slide, 2 grains of salt is what we're looking at as a lethal dose. Again, it doesn't take much. Also looking at how and realizing how these products are manufactured. So, they're not always uniform. So just like if you mix up, cookie batter or something, and you don't mix it well, you may get a pocket of mostly flour, or maybe all the chocolate chips are in one area. If it's not well mixed, these are not standardized products, and the production is pretty haphazard. And so it's really easy to get deadly product. These are some older photos now. Back in 2017, we first started seeing fentanyl in the Houston area drug market about 2016, 2017, pretty sporadic. It's pretty routine now. These are pill presses that can be purchased off the internet, particularly the dark web. You can also purchase dye molds to make products look like legit branded medications. Also appeal to a younger demographic, basically make the pills look like anything you want. These particular machines will crank out about 5,000 pills an hour. And this was a bust off the 59 Southwest Freeway, in a, it was a rented storage facility. Here's a little bit more sophisticated pill press, maybe a little less contamination in these pills, because at least it's covered. It's not, just sitting out here with all the dust and debris and, things that you might find in a storage facility that's unregulated. And this one will crank out about double that, about 10,000 pills an hour. Again, you can see these are made to look like branded products. This looks exactly like a branded Xanax. This is an oxycodone branded illicitly manufactured product, and another hydrocodone product. So again, these can look like anything. There's a link to this infographic because I realize it's kind of small, and they have additional information, for our young folks and our families. As a parent, what can you look for, and what can you do? One thing is to ensure that you're talking frequently with your adolescent about just what's out there and the one pill can kill message. I think that's really strong and simple. Some things to look for, in terms of text messages that you might see on the phone, etc. There's some common emoji codes for drug use. And so you can see those here. And that can be helpful in monitoring as well. So, what do we do about fentanyl? I don't know that we have any law enforcement here in attendance. I'm certainly not in the criminal justice realm. What can we do from kind of the public health side of things, from the behavioral health and counseling perspective? One of the things is harm reduction and really getting that message out there. One pill can kill. This stuff is in everything these days, or could be potentially in anything, any product that you get that's not purchased legitimately from a legitimate pharmacy. But what we want to do is make sure that if someone does encounter fentanyl, that they survive the encounter, or that they're more likely to survive the encounter, so that then, hopefully they can get help and avoid using again in the future. So we talk in harm reduction, and there's a link to, a more robust website for this information about go low, go slow, buddying up for use, test strips, and naloxone. And I'll talk a little bit about each of these, so you know what's out there and what you feel comfortable sharing with the folks, your loved ones that you're concerned about, or folks that you're working with in a professional capacity. So we do encourage, if people are still actively using, that they always start with a test dose. Again, that's no guarantee. That first little bit that you push or that you ingest or snort or smoke may have those little 2 grains of fentanyl in there, or the equivalent, and be lethal. But if you try a test dose and it seems stronger than what you're used to, or you get a different reaction than you're used to from that particular substance, so you start feeling more sedated, and you just used what you thought was a usual dose of your methamphetamine, then you need to be thinking, is this contaminated, and do I want to keep using it? The most common time to overdose for folks is after a period of abstinence, like when they're discharged from a hospital stay. They're released from jail or prison, or if they've gone into treatment for their substance issue, but that treatment did not involve them getting on medication therapy for their opiate use disorder. So they've lost tolerance. Most people, when they relapse in those situations or go back to use, they go back to the level of use that they were used to before they were hospitalized, or before they were incarcerated, or before they went into treatment for their SUDs. And what we know is that any tolerance that they have to opiates starts to really fall off quickly past 3 to 4 days of being away from opiate use. So if someone's not used an opiate in 3 or more days, we really, again, we don't encourage them to use at all. But if they're going to use, we encourage to start with a smaller dose. Same thing if, they're changing suppliers, they're trying something new for the first time. So maybe they've been doing just cannabis and now they're going to try methamphetamine for the first time. They're using by a different route. So they're going from popping a pill to crushing and snorting it, or, from snorting cocaine to smoking it, or from snorting heroin to injecting. Again, none of this is fail-safe. The fail-safe thing to do is for folks not to use, but while they're getting help and figuring out that they need help, and maybe realizing that they want to engage in treatment and getting effective treatment, at least this can help. These techniques can help people stay alive and survive, be more likely to survive fentanyl exposure, so that they can get help in the future. Another technique is to buddy up. So again, harm reduction technique, never use alone. And there's a website, never use alone website, I've put a link to here. Plan use with others, taking turns of who's injecting, etc., not using at the same moment together. So that one person could respond if the other person is an overdose. Safer injection sites. So these are programs where people go, they're monitored typically not by licensed medical personnel, but they are monitored by folks at these facilities, oftentimes peers that are in recovery, and sometimes even peers that aren't in recovery staff these centers. These are not legal, so you won't find them, at least not on the up and up in Texas, but they are out there, and folks have probably heard of them and heard of those controversies. You can, if you're using alone, notifying a trusted person of that use and either staying on the line with them or staying in constant text contact with that person while you're using, so they can respond if they see you, completely not out and become unresponsive, and get EMS services to you as soon as possible. There's also now apps and websites that help you do that same thing. So our hotlines, and one is this Never Use Alone hotline. So that's staffed 24/7 by volunteers who will stay on the line while people use, after getting, location, etc., so that they can send emergency response if someone during their use episode overdoses. And then kind of on the horizon in terms of harm reduction, there are a number of studies ongoing for naloxone wearables. So what the idea behind this is that someone would have basically a naloxone and something that a device that could administer naloxone, that they would kind of have on as a patch or a stick on. Anybody here in attending today who's ever had a like continuous glucose monitor wearable attached to them, it'd be something very similar type in size, etc. And obviously the naloxone wouldn't be administered unless some sensor, and again, that's where the tech comes in and is being tested, gets a sensory input, a measurable input that this person is likely an overdose, and then it would administer the naloxone. So those are still, to my knowledge, there's nothing out yet that's an naloxone wearable, but there are studies ongoing for that. Okay. Test strips are another harm reduction technique, also engender some controversy as well. There are now test strips for both fentanyl and xylazine, which I'll mention at the very end today, because folks have probably started to hear about that infiltrating the drug supply as well. Test strips are still considered drug paraphernalia in the state of Texas, so they are illegal here, used outside of licensed medical facilities. You can imagine that studies, of test strips on illicit drug supplies have shown them to be fairly accurate at detecting fentanyl. But you can imagine if a product is not well mixed, and you're asking a user to take a little piece or the residue from the baggie and test that with the test strip, that it might miss part of that sample that actually had the fentanyl in it. So these are not fail safe. These test strips also just tell the person that's doing the testing that yes, there's fentanyl in there, or no, there's not. It doesn't tell the person how much is in there. Again, they're not super accurate. There's also some concern and been some reports in the harm reduction literature about cross reactivity with methamphetamine. So that meth only samples sometimes test positive for fentanyl as well anyway. So just some issues around test strips. And again, not legal here in Texas. And then we have naloxone, which we can use, and I encourage everyone to have naloxone on them, keep it with them, and know how to use it, because you just never know. There is some controversy around naloxone as well, but I think more than some of these other harm reduction ideas and methods, we really moved a long way to recognize that Narcan, naloxone, it enables people to breathe. That's all it does. It enables people to live, to see another day, and to have that hope of recovery. It is available over the counter now. It costs about $44 for 2 doses. UT San Antonio has a federal grant to distribute Narcan around the state, or naloxone doses around the state. You can check out their website, morenarcanplease.com, to get that shipped out. With naloxone, some things to remember, particularly around fentanyl. If someone has fentanyl on board and that's part of their overdose, because it is so potent of an opioid, it's not that naloxone won't work, just as that it may take multiple doses. So it's not unheard of to take 2, 4, 6 doses of the over-the-counter nasal spray naloxone to reverse a fentanyl overdose. Also important to remember, regardless of what opioid overdose you're reversing with the naloxone is going to wear off faster than the opiate. So if you don't get this person to ongoing medical care emergently in 30 to 90 minutes, when that naloxone wears off, that opioid's going to kick back in and that person can go back into overdose. So it's really key to try to link that person to care. And if they're refusing to go, or there's no access to care where you're at with the person, at the very least, staying with that person for the next 4 to 6 hours. We always train around using naloxone, when in doubt, give it out. So, sometimes, you may just be, seeing someone on the street, or, passing someone by. You don't know what they've used. If you're in doubt, but you have naloxone and they're not breathing, or they're breathing less than 8 breaths a minute, you will do that person no harm to give them the naloxone. If they don't have an opiate on board, it really will do nothing. It won't help, but it won't do any harm. So it is okay to give this. You don't have to be 100% certain that the person's used an opiate, or in particular fentanyl, to give naloxone out. It's better to err on the side of caution and give it than to withhold it, because again, it won't do harm. And the main sign we're looking for that someone is overdosed and possibly an opioid is involved, their breathing rate will be below 8 breaths a minute. And that's not breathing slower than 8 breaths a minute, and being unconscious and breathing slower than 8 breaths a minute is really not compatible with sustaining enough oxygen in your system to maintain the health of your organs, your vital organs like the brain, the heart, the kidneys, etc. So that's what we really encourage you to look for. If someone's out of it and they're breathing less than 8 breaths a minute, go ahead and give the naloxone. Call or take them for emergency medical care, and then long-term, hopefully get that person linked to treatment services. So a little bit about treatment. Unfortunately, non-medication only treatment, so just, for example, 28-day residential treatment or longer, outpatient treatment, counseling therapies, etc., they only have about a 5% long-term success rate for people with opiate use disorder. With medication treatment, we can increase success rate to about 50%, which is still, we still have a big gap there, but 50% is about a lot better than 5%. And we have 3 medications now to use for opiate use disorder and approved for use in the US. Buprenorphine, most commonly known as Suboxone, is one of the branded products. Methadone, which is the oldest medication we have for treating opiate use disorder in this country, and then naltrexone or Vivitrol, which is an opiate blocker and is a non-controlled substance, unlike buprenorphine or methadone. Some things that have been looked at and have yet to be proven. I'm not going to say definitively that they won't ever be proven to be effective for treating opiate use disorder, and some are just now starting to be explored for that use. Kratom, which a lot of my patients that I see with opiate use disorder have tried at some point in time to help them come off on their own, their opiate use. Ibogaine, which is ketamine, psilocybin, and various what we call psychedelic medications have been looked at and have various degrees of strength of findings of those studies, but none are ready yet for prime time for treating opiate use disorder. And then teasingly on the horizon, being studied right now, I believe more for alcohol use disorder, but they're looking at, is it cutting cravings across the board? And that is the GLP-1s, which were originally developed for treating diabetes. These are medicines like semaglutide, which most people know as Ozempic. So again, these studies are just getting started for various substance use disorders and the GLP-1s. So way too early to call that, this would be effective. But there have been incidental reports that, folks getting these medications, these type of medications for diabetes or weight loss, now that their use has really exploded around weight loss, have found that their substance use has been tempered or completely stopped with use of these medications. So intriguing, but we're not there yet. So what we are there with and what we do have good data on are the current medications for approval. We have buprenorphine, which comes in a film or pill form, which dissolves under the tongue. There's also a film that you can tuck inside your cheek, and it will dissolve there as well. These can be prescribed and delivered through telehealth services, through pandemic exemptions that keep getting extended, even though the pandemic is over. So no in-person office visit is necessarily required, at least at this time with current regulations. So that can be helpful for folks that live kind of out or not near services, etc. An 8 to 24 milligram total daily dose is most typical, tend to be the higher end of that range, and sometimes 32 milligrams when fentanyl is involved. It's a partial opiate, so it is a controlled substance. It will show up on a tox screen if you specifically look for it. It won't show up on an opiate. You have to specifically look for buprenorphine. What does a partial opiate agonist mean? It means it turns on those opiate receptors to 50%. So a full opiate, things like morphine, heroin, fentanyl, methadone, turns them on 100%. This sits on the receptor. It sits on there tighter than any known opiate. So that means if people try to use on top of it, they won't get an effect from the opiate. It'll just be the buprenorphine effect there. At 50% receptors activation, or the receptors all turned on at 50%. Most people that have opiate use disorder won't have cravings or withdrawal. They won't feel high either. They'll just feel normal. And that's how this medication works. It stabilizes those receptors and they just feel normal. Many people with opiate use disorder, when they've been suffering with the disorder for more than a year or two, will report they're not even getting high anymore. They're using to not feel sick. And so this is a legal safely manufactured and produced pharmaceutical medication that allows them to not feel sick and not be exposed to fentanyl on the street and not have to engage in all those activities to get their illicit drug supply. It also lasts a long time in the body. Its half-life is 36 hours. So that means once daily dosing is fine for this medication. Although a lot of my patients that are on 2 or 3 of these typically comes in an 8 or 12 milligram film or tablet. We'll divide it up across the day, mostly because that's how they were used to using their illicit substance. Sometimes for to address their chronic pain issues as well. It is a partial agonist, which means there is a ceiling effect, which means higher doses don't get you any more bang for your buck, so to speak. Once you get above about 32 milligrams total daily dose, 99.9% of us that would take that high of a dose, we would have 100% of our opiate receptors have buprenorphine attached. So there's no more. If you take more, you're not doing anything. There are no long-term impacts to kidneys, heart, liver, lungs from this medication. We don't have to monitor liver or kidney function while people are on it. Constipation is the most common side effect because it is a partial opiate, and opiates constipate us. They slow down those peristalsis or those waves of contractions that move our food and, ultimately our stool through our gut system. It can be a challenge transitioning people, particularly from fentanyl onto buprenorphine. There are lots of new protocols out there that seem to work better called microdosing. So it doesn't have to be a big, bad, uncomfortable experience for folks. And any clinician now, since about this time last year, can write for this medication. You don't need a special DEA number. As long as you have a DEA number to write for things like narcos and things, you can write for this. I won't go into methadone. I know we're getting close to time and I want to leave time for questions. That can only be dispensed in a licensed methadone facility, and that really limits, how people can access it and just, can be a big burden to have to go to a clinic to take medicine every day versus, getting a prescription from your routine pharmacy and taking it in home. It is relatively cheap therapy though, and it is pretty effective. And for those particularly that are heavy users of fentanyl, sometimes their tolerance to opiates is so high that even at max buprenorphine doses, they're not comfortable. They're still having cravings and withdrawal. And those folks really can benefit from methadone. And then we have naltrexone, which is an opiate blocker that actually binds onto the opiate receptor tighter than any known opiate, which means when people have this medication on board, they can use opiates and they really don't get anything out of them because the opiate can't get in there and bind those receptors. There are two main issues with the naltrexone product that make it a bit challenging to implement in real life. One is someone has to be off all opiates and a partial opiate, so even Suboxone or buprenorphine for a full 7 to 10 days before you can start this, or you will put people into fluoride withdrawal. And a lot of times people can't tolerate that 7 to 10 day washout period. We find the greatest success starting people on Vivitrol when they come out from those settings that I talked about way before in harm reduction, where they've been hospitalized and without their opiate for a time, coming out of jail or prison. And there are a lot of programs around the country now, including in our area, where folks that have an opiate use disorder and are being released from jail or prison after at least a 2-week stay are offered a Vivitrol injection. And it does come in an oral form that has not been shown to be effective for opiate use disorder. It's the monthly injectable. Besides that how to get people on, and it's very tricky getting them on the medication unless, again, they've had that period of sobriety or time away from their opiate. it's cost factor. And so these are costly injections. It's about $1,500 a dose, and people do have to go monthly in to see their provider to get that dose. I will not talk about xylazine and tranq, but just to know that it's out there, it's the next thing coming. And we're seeing fentanyl, heroin, mostly opiate products and things that are labeled as opiate products on the illicit drug market be contaminated or this being actively included. It is not an opiate, so naloxone does not work on it. And it really increases the high and how long people stay out of it when they use it along with an opiate. There are now point of care tests available, so that is good news. But there are a lot of issues with xylazine, also known as tranq, and I put a link there. I'm going to take a look at chat. I have a question from Emily. Thank you for that. Why is fentanyl added to other street drugs? So for some street drugs, other, kind of sedating or depressant street drugs, like benzos, like Xanax and things like that, it's added because, it kind of really ramps that up, right? And for the stimulants, your guess is as good as mine for that. I mean, it's another thing that people can become physically dependent on, so it can make the user physically dependent on that product. Whereas, your stimulants, methamphetamine, cocaine, typically don't cause physical dependence. They cause that mental or behavioral dependence on their use, but you don't get a physical withdrawal syndrome when you stop them cold turkey. So there's some guess that that's why it's being included. A lot of folks that I encounter that have long-term stimulant use disorder, they don't like downers. They don't like that feeling accompanying their stim use, but some are actually used to using either co-administering or at the same time. So like doing a speedball where they're combining both the stimulant, methamphetamine or cocaine, typically with heroin or fentanyl, to kind of balance out that high and smooth out that high. Others will use sequentially, so they'll go up and then they'll bring themselves down, etc. And so I guess for those folks, it's kind of like your combination blood pressure pills, right? You don't have to get so many different products. It's all in one. Really don't know. Is there a way to test a pill for fentanyl? So what's encouraged in the harm reduction world, you'll hear folks train around this and training people how to do this, taking a little, just scratching a little bit, getting a couple little pieces of the pill off, a very small amount, a little residual dust from the baggie that it might have came in, etc. So you can see that there could be issues with that though, right? Because it may not be uniformly distributed within that pill. And so people can have a miss that way.
Are there any other questions? Please just type them in the chat.
I hope this is helpful for folks.
Well, if not, thank you, Alicia, today. That was wonderful. And I do think it is, I always ask that same question myself when I come to presentations like this. Why would they be putting this deadly drug in there? I guess we'll never know, but I imagine that more people get addicted by doing that. And so the loss of life is not really something they're concerned about. So it's must be a cost benefit thing for them, but it's pretty frightening to imagine the cost. Well, all right, well, thank you, everyone. We will be sending out a link to this recorded presentation to everyone who registered. And if you have any questions or interested in more information about substance use recovery, you certainly can contact the Hope and Healing Center. Have a good day. Thank you.
Thank you. Thanks again for the invite, Matt.